Hi, I'm Ana de Oliveira Pereira, and I'll be talking about healthcare costs in the United States. There's a belief that greater healthcare spending in the US means better health outcomes. Studies comparing outcomes with other developed countries have showed otherwise. Controlling healthcare costs has unique challenges and can be compared to taming a voracious dragon. $3.5 trillion. That was the cost of healthcare in the United States in 2017. This is equivalent to 17.9% of the gross domestic product of the United States, GDP. Healthcare costs have consistently increased since the 1960s, rising above the average annual income. Increase in healthcare spending can be due to increase in utilization of services or price for services. Currently, 90% of the U.S. population is insured. U.S. healthcare utilization is similar to other developed countries, although it has the largest spending per capita among them and lower comparative health outcomes and life expectancy. Private insurance is the primary form of insurance for 55.3% of covered Americans, but the government is the single largest payer through CMS, Centers for Medicare and Medicaid Services, benefiting about 90 million Americans through Medicare, Medicaid, and the state's Children's Health Insurance Program. The U.S. has surprisingly low out-of-cost spending. Patients tend to avoid seeking care or skip consultations to avoid high costs through copays or deductibles. The poorest have higher out-of-pocket spending and rely on the most overpriced acute care system for healthcare needs. Major government attempts for Medicare cost control started in 1973 when President Nixon created healthcare maintenance organizations. In 1974, corporations self-insured became exempt from state regulations and taxes. In 1997, Medicare decreased payments to providers, leading some off the market. In 1999, the Balanced Budget Refinement Act provided differential payments to critical access, rural or teaching hospitals, allowing some hospitals to reopen. In 2009, the Affordable Care Act expanded health care insurance access and services. Providers became more accountable for health outcomes. Among other factors, demand created by new technology, populational aging, and practice variation among providers based on preference or geography have long been deemed as responsible for the high costs of healthcare. The mix of private and government-funded insurances creates an imperfect or quasi-market. Price checks and service utilization is difficult to control. Price for services may not reflect their true costs, which are kept in secrecy by providers in the name of competition. Different payers may be charged variable prices for the same services. Many chronic illnesses, as diabetes and heart disease, are preventable, but they are present in almost 50% of all Americans. They are responsible for 85% of healthcare costs, mostly through Medicare. The sickest 5% of the population consume 50% of total healthcare costs, especially in their last year of life. Physicians and non-physician services prices are higher in the U.S. compared to other developed countries. A 2018 study did not show significant difference in number and percentage of U.S. specialty practitioners compared to high-income countries. There is debate on whether U.S. physician salaries are too high or other developed countries' physician salaries are too low. Pharmaceutical spending in the U.S. is around $1,400 per capita, followed by Switzerland at $900. 80% of the U.S. residents' prescriptions are filled as generics, but 70% of pharmaceutical expenses are on brand name medications. Costs can be decreased by medication importation and upper payment limit reforms. Medicare auctions can provide competitive bidding for drugs, devices, and services, but have failed in some states due to unsustainably low prices, unfair qualification procedures, and lack of transparency in awarded contracts. A good auction market design should involve government officials, auction experts, and industry representatives. Healthcare administration costs include marketing, management of finances, and enrollment, among others. It makes up to 30% of healthcare spending, or 8% of the GDP. Implementation of standardized electronic data expects to decrease these costs, although it requires more supporting IT personnel with possible negligible savings. Costs refers to total cost of the full cycle of care for a patient's medical condition, not for individual services. Cost control should consider health outcomes to avoid limiting necessary and effective care. Evidence-based healthcare can direct expenditures for some services and decrease the need for others. Value is defined as health outcomes per dollar spent. High value for patients should be the goal for performance in healthcare. Measuring, reporting, and comparing outcomes contribute for evidence-based guidelines, quality of care, and reducing costs. Value improvement in healthcare benefits all stakeholders through economic sustainability. In the outcomes measure hierarchy, there are three tiers of decreasing importance. Tier 1 refers to quality of health achieved or retained and functional status. Tier 2 to the process and duration of recovery to normal or attainable function, which is influenced by delays in care, retreatment, and medical errors. And Tier 3 to sustainability of health. Transparency of outcomes among providers and patients can drive innovation and avoid non-value adding services. Current reimbursement practices are misaligned with value. Providers' cost disclosure is needed. Measuring true costs for individual patients and not averages in care for similar patients can assist with cost containment. Higher U.S. healthcare costs, in comparison to other developed countries, seem to be due to higher prices for labor and goods, pharmaceutical and administrative costs. Greater spending does not equal better outcomes. The Affordable Care Act has started shifting focus of healthcare quality delivery from high-cost spending to high-value care. Healthcare cost control can be an attainable goal disguised as a dragon, but it will require a few efforts as measuring true costs and health outcomes, reallocating spending to more beneficial services accordingly, and designing more value-driven, patient-centered health policies. Failure to do so will make healthcare unmanageable in just a few years.